Hello again from Axxess. This is Jennifer Gibson, your trainer, and today we're going to be talking about the PreClaim review model again. Today's session, we're going to talk about some of the history that led to PreClaim review and the authority that CMS has given the MACs to actually do PreClaim review. So welcome and thank you for joining us again today, and let's go ahead and get started. Our objectives today are to learn the facts that led to PreClaim review, to understand the authority behind the PreClaim review process, and then gain some knowledge of some of the triggers and the red flags of improper billing and fraud that led to the PreClaim review. Now, the Centers of Medicare and Medicaid Services have given the Medicare Administrative Contractors, or MACs, the authority to review any claim at any time, and we know that that happens because we get ADRs from time to time for no apparent reason sometimes, and sometimes they announce a probe, for example. Because of the volume of claims, the MACs do not have enough time to review every claim, so CMS has told the MACs that they must set priorities. The MACs are to target their efforts at those services and items that pose the greatest financial risk, and they should focus edits where the services billed have significant potential to be non-covered or incorrectly coded. The MAC shall initiate a targeted provider-specific prepayment review only when there is the likelihood of sustained or high level of payment error. And those are quotes actually from the Medicare Program Integrity Manual, Chapter 3. The reason I want to let you know that is that's what CMS has given the MACs as far as authority and priorities, and they specifically mentioned a provider-specific prepayment review in that manual. So now we kind of see the background of why this has come about. Now let's talk a little bit about those reported issues that gave the MAC the authority or the initiative to go ahead and look at PreClaim review for some of our areas. According to the statistics for 2015, there were 11,000 home health agencies, according to the National Medicare Annual Statistics. And those 11,000 home health agencies did 7 million episodes of care, totaling $18.4 billion in revenue. During the period between 2011 and 2015, the OIG investigations have resulted in more than 350 criminal and civil actions between that period of time, and that has resulted in $975 million worth in receivables, or money that CMS has recouped from these OIG investigations. So clearly, we have a problem as far as CMS and our MACs are concerned. It's estimated that over $10 billion in improper payments were made in fiscal year 2015, and there are previous reports that highlight billing and compliance concerns. Now, the majority of fraud cases involve agencies who bill for services that are either not medically necessary or just not provided at all. So obviously there's some red flags that CMS and our MACs are looking at, and we're going to get more specifically into those targets and red flags here. Now, we know going back to July of 2013, a moratoria for new home health agencies were implemented in these areas, especially the areas in the Miami-Dade County area of Florida, Dallas, Texas, Houston, Texas, Chicago, and Detroit. And the reason for that moratoria was to help really get a handle on the fraud, waste, and abuse going on, especially in those areas. We also know that recently the OIG published a report, and they showed 27 geographic hotspots where they're really concerned about overutilization and fraud and abuse and so on as well. And that's the map that you see here. And these hotspots were identified through analysis of Medicare claims data. You're going to notice that these hotspots are spread throughout the United States, but they're really concentrated in the states of Texas and Florida. And of course, we know there are a lot of Medicare beneficiaries in those areas just because of climate and it's popular retirement areas. But there also seems to be some issues of concern in the LA and San Diego area, Las Vegas, Nevada. We've got some in Utah. We've got some in Phoenix, Oklahoma, Louisiana, Chicago area, Detroit, Philadelphia, New York, and Massachusetts. Now, you'll also notice, according to the image that you see here, 5 of these states are also states that are in the PreClaim review model. And those are, of course, Illinois, Florida, Texas, Michigan, and Massachusetts. So some of these areas have been on the target for quite a while. Let's talk now about some common characteristics of fraud and what Medicare calls outliers. Now, when we talk about outliers in the home health industry, we tend to think about payment outliers, those patients who require a whole lot more care than maybe other patients and a lot of expenditures as far as money and payment. But in this case, CMS characterizes hotspots or red flags as outliers. And there are 5 distinct characteristics or 5 distinct outliers to certain fraud cases according to CMS's and OIG's criteria. The first one is a high percentage of episodes for which the beneficiary had no recent visits with the supervising physician. And when you think about the Medicare criteria, especially for face-to-face encounter and certification and all of that, CMS is looking at what we're putting down as the home health agencies as the date of the face-to-face encounter, and then they can also compare that with the physician billing records and see that there was indeed no physician visit billed on that day. So how in the world could the patient have had a face-to-face encounter? So that's again is a red flag. So again, we're looking at episodes for which the beneficiary had no recent visits with the supervising physician. That's also very important if the patient has been on services for several research periods. And again, there's no billing done by the physician that patient has come in to see them for maybe months or even years in some cases. And that's obviously a problem as far as CMS is concerned. The second criteria are those episodes with a high percentage of patients that were not preceded by a hospital or nursing home stay. So we have a lot of patients who are admitted to home care that have not been in the hospital, they haven't been in a nursing home. And of course, we in the industry think, well, that's fabulous. We've kept them out of those facilities. But CMS tends to look at it as a different perspective in so much as this patient clearly hasn't had an acute episode of illness and they go right into home health. Why is that? Now, it's not to say that you shouldn't admit those patients, but certainly your documentation should clearly demonstrate that something was going on with that patient. There was a lot of communication between your agency and the physician. It highly demonstrates what those problems were and what you're doing about making those problems better. The third outlier is a high percentage of episodes with primary diagnosis of diabetes and hypertension. Now, CMS looks at that particularly because these are chronic illnesses, and if the patient is on your services for diabetes or hypertension, if that's the primary reason for home care, they're really looking for evidence by the physician and coordination of your agency that this patient has had an acute exacerbation, that something's out of control, there's treatment changes going on, and something else is happening rather than just routine or maintenance care, because that is not a skilled service as far as reasonable and necessary criteria by CMS. The number 4 criteria, high percentage of beneficiaries with claims from multiple agencies. We know that we can look in our DDE systems or in the common working file and identify those patients who have had episodes of home health care before they were transferred to our agency. You know, CMS is looking at it more from the perspective of the patients had 3 episodes of care and then they had a period of time less than 60 days before they came onto your agency's care. So they've really had uninterrupted care for a very long period of time. And CMS does not make the distinction between whether or not that was your agency or another agency. They just see it as a big episode payment, beneficiary expenditure for that patient, and they're wondering whether or not the patient's getting skilled care. So we have to look at that as well. The number 5 outlier characteristic is a high percentage of beneficiaries with multiple home health readmissions in a short period of time. If the patient is admitted and discharged and readmitted and discharged and admitted and discharged again, you know, I've heard urban legends that helps out with the agency because you're not having a long length of stay. And again, what I want to remind you is that CMS has the ability to look at it on a higher level. And they're not just looking at the time period, they're looking at a bigger picture of uninterrupted episodes of care, and they consider it to be uninterrupted unless 60 days go by between the discharge date and the next start of care date. So from that perspective, you really need to make sure that you understand who cared for that patient before you did, what is it they did for the patient, if you can even gather that information. We know that's a challenge. But certainly when we get in, we need to make sure we have our needs met and the patient's needs met, more importantly, before we discharge, because discharging and readmitting that patient is not helpful as far as the perspective of CMS. Okay, this next slide is a table that shows the number of outliers or characteristics by the home health agencies and the physicians. And again, this comes from the OIG's analysis of Medicare claims data, both for home health care and physician billing. And what I want you to show you is in each of these columns, there are a number of outliers that either have 2 characteristics that we just mentioned in the 5, or 3 characteristics, or 4 characteristics, or all 5. For home health agencies, 469 agencies had at least 2 of those outliers that we just went over. 84 had at least 3 of those. 9 had 4, and thankfully we didn't have any agencies that had all 5, but a total of 562 agencies out of the 11,000 that we mentioned at the very beginning had outliers in those 5 characteristic areas, and usually a combination of more than one. For physician offices, this really blew up even more. There were 3,844 physician providers who had at least 2 of those characteristics, 570 that had 3 of the characteristics that we went over, 86 had 4, and 2 had all 5, for a total of 4,502. So we can see, obviously, that there are some issues. Now, that could be because we don't understand what we need to do. It could be, several different factors, but certainly as CMS sees it, they only see fraud and abuse because they see that we're billing for things that maybe weren't provided or weren't provided under the guidance of Medicare, as Medicare outlines in their prerequisites for even getting the care to begin with. So in the prior slide, we were talking about the columns where the physicians and the home health agencies had multiple outliers, but let's look again at the ones that had maybe even just one. So how many different agencies and physicians had outliers at all? According to CMS's OIG report, again, we had a total of 470 home health agencies and 16,789 physicians who had outliers on the percentage of home health episodes for which the beneficiary had no evaluation and management claims from the supervising physician in the preceding 6 months. And again, that's a big deal. That's a problem because we know the face-to-face criteria is that that patient must have had a face-to-face encounter between 90 days before the patient was admitted to home health and or 30 days after. So sometime between the first 30 days of admission or 90 days prior to that. So if records from billing show that that patient has not seen the physician in over 6 months, we clearly have a problem. For these 470 home health agency outliers, at least 63% of those home health episodes fit that description compared to a national median of 23%. So what they're looking at is that across the nation, if you average all the episodes, that average turned out to be 23% of agencies that had an issue. But in these particular agencies that flagged with these outliers, that went up to 63%. So that's kind of where CMS and OIG's focusing in on these hotspots because they're areas where clearly we have a higher percentage than the normal national average. Now, for the 16,789 physician outliers, at least 55% of home health episodes fit the description compared to the national median of 12%. There were also an unusually high number of episodes that were not preceded by a hospital or skilled nursing facility discharge within the prior 30 days. There were an unusually high number of episodes with the diagnosis of diabetes or hypertension. There was an unusually high percentage of beneficiaries who had claims from multiple home health agencies, and then a high percentage of beneficiaries who had multiple home health readmissions in a short period of time. Statistically speaking, let's see what we have when we look at it as far as the annual statistics. So again, remember we had 11,000 home health agencies. We had 7 million episodes of care totaling $18.4 billion in 2015. Now, in those 27 geographic hotspots that we talked about earlier, the problems that we saw was that just in those 27 areas alone, they were responsible for 2.4 million episodes of care. So 2.4 million out of 7 million, just in those 27 areas. And they were also responsible for $6.9 billion of the $18.4 billion total. So we're looking at in those 27 geographic hotspots, you have 35% of the episodes of care total and 37% of the expenditures nationally out of all the 50 states. So clearly, again, when you look at trends, we see kind of why CMS is starting to focus in on these areas and try to make some measures to focus further. So as we talked about earlier, one of the first waves of focus when CMS began looking at data and really piecing things together, they first put out the moratoria for Medicare home health agencies opening and becoming certified to serve patients. Now, back on July 29th of 2016, CMS went ahead and extended that moratoria for at least an additional 6 months in the areas of Dallas, Texas, Detroit, Michigan, Fort Lauderdale, Florida, Houston, Texas, and Miami, Florida. So that will continue to go on, and they may continue to extend those moratoria several more times for all we know. They review that and make decisions accordingly as time goes on. We also had Probe and Educate ADR, and that was sent out by the Medline Learning Network, MLN SE 1524, and that's when CMS directed that the MACs send an ADR request probe to every Medicare certified agency in the country, and each Medicare certified agency received 5 prepayment ADRs, and they were looking at claims from August 1st, 2015 and after. They were looking specifically for certification of the patient's eligibility to receive Medicare-funded home health services and the face-to-face encounter compliance. Now, when you got your 5 prepayment ADR probe records and you sent those in, the response that you got back determined whether or not you would have more reviews coming. If you had 0 to 1 denial out of the 5, there would be no more Probe and Educate ADR reviews, at least not under this particular ADR probe. If you had 2 to 5, however, the MACs were authorized to do 5 more probes and see if there was something not quite lining up. They also had the opportunity to educate home health agencies, and you could sign up for education on what it was that you were or were not doing to meet the criteria so that in the future you could become compliant. And hopefully you guys signed up and listened to that education from the MACs because they're very specific and very clear about what they're looking for. Now, the Probe and Educate ADRs, again, we're talking about the one announced in SE 1524, where each Medicare certified agency received 5 prepayment ADRs, and they were looking again for certification of eligibility and face-to-face encounter compliance. The bad news is that, depending on the MAC, there was up to 97% of the claims that were reviewed, they were denied because either certification was not up to par or the face-to-face encounter documentation was not up to par. So obviously, again, we either don't have a clear understanding of what CMS is looking for, or we're going ahead and billing, and we shouldn't. These are conditions of billing issues, but we must clearly have a problem with agencies billing before the eligibility and face-to-face encounter information is clearly documented. So the Probe and Educate ADR denials, with that high of a percentage, of course, that opened the door for more scrutiny. Agencies either couldn't or didn't show proof of criteria, so of course Medicare wants to take a closer look. And that's how we find ourselves in the middle of PreClaim review in that environment. So now that we've looked at the history and the data, we can better understand how we are in the PreClaim review environment that we are in today. And so for that reason, we want to review the Medicare home health benefit criteria and see what it is that the patient must meet in order to receive traditional Medicare home health payment to begin with. So under Medicare Part A and or Part B, and Section 1814A 2C and Section 1835A2A, we see that CMS states that when the patient is referred to home health from the physician, the patient must be confined to the home, they must be in the need of skilled services, they must be under the care of a physician, they must receive services under a plan of care that's established by and reviewed periodically by a physician, and they must have had a face-to-face encounter for their current diagnosis with a physician or allowed non-physician provider. So now that we've looked at some criteria and data and information about why we're in the area that we are with PreClaim review, let's talk a little bit again about the home care benefit and the ADR probe. Now clearly CMS had told home health agencies that we have to be able to provide upon request supporting documentation that substantiates eligibility for the Medicare home health benefit to any review entities and or CMS. And what that means is if you get an ADR or you get a ZPIC or a RAC audit, whomever is looking at your records, you should already have in your documentation, in your patient's charts, information that supports that all the criteria were met before you even billed that claim. Now, the documentation used as base for certification of eligibility, if it's not sufficient to demonstrate that the patient is or was eligible to receive services under that Medicare home health benefit, then payment will not be rendered for the home health agency services provided. Now, clearly in pre-claim review, they're looking at that before they even send the money out. But for the agencies who are not in pre-claim review, you still have to worry about this because you can get ADRs or you can get a ZPIC or a RAC audit at any time. And you also need to have this documentation before you bill your final claims, because if they come in and review and see that you didn't have that documented well from the physician, they can come back and take your money after the fact. So remember, services, number one, the services shouldn't be provided if that patient doesn't meet the eligibility requirements, and certainly that care should not be billed for if the patient doesn't meet the eligibility requirements. In pre-claim review, the agencies have to provide documentation that substantiates eligibility for Medicare home health benefit to the MAC up front. And that's a little different than the environment that we've operated in before. If the documentation is not sufficient to demonstrate the patient is eligible to receive services under the Medicare home health benefit, payment will not be rendered for the home health services provided. Now, a lot of agencies really worry about that because they're, well, how do we know and how are we going to know up front whether or not we're going to pass pre-claim review and if it's going to get an affirmation or not? And so we're going to talk about that for just a moment. Remember as well that pre-claim review and prior authorization are two different things. With prior authorization, you have to send in a request, and then that request has to be reviewed, and then they get back to you and says, okay, you're good to go. You can go out and do 5 visits. And you know that before you can provide any services. Well, obviously, CMS is not going to have us do that because that could cause some beneficiary problems as far as their health and getting to the services they need. So in that case, pre-claim review is a little different. And with pre-claim review, it's up to us as the agency to review the referral documents and see whether or not the patient's going to meet that criteria. And between the documents that we look at and then our admission visit, we are able to assess or should be able to assess whether or not we believe that patient meets the criteria to begin with. And then we take all the evidence that we've collected and document that, and that's what we're sending in to the pre-claim review person who's going to actually review that. So you're basically gathering evidence, documenting that evidence, and then submitting the evidence that the patient met the criteria. That's what's a little bit different. Beforehand, we gathered the evidence, and we might have known this in our head, but we might not have been the best at documenting so that anyone who comes behind us 2 and 3 years later can clearly see as well that this patient met the criteria. So we're having to really think about doing that up front in pre-claim review. Remember, in pre-claim review, the requests are submitted after the initial assessments and intake procedures are completed, the services have already begun, and before you do your final claim. So again, we need to ask ourselves as home health agencies and assessing clinicians and admitting clinicians especially, we have to look at the referral information and the assessing clinician information, and that should provide us enough information to make a decision. So if upon reviewing your referral information and the admitting clinician going out and assessing the patient, if a decision is made that, wow, we really don't have enough evidence here to know that this patient meets all the criteria, either, they meet all 4 but they're not homebound, or they're homebound but there's really not a skilled service here, or whatever the information might show you, if the patient doesn't meet all 5 pieces of that criteria, then the physician should be notified and the agency should decide to do one of 3 things, or you may even have some other solutions, but certainly you have to decide whether or not you're going to admit the patient, because if you admit the patient anyway, you may not be able to bill Medicare Home Health and get paid for it because they don't meet the Medicare benefit criteria to begin with. Now, some agencies will say, well, even if Medicare doesn't pay, we'll still need to care for this patient because they clearly need the services. They don't have another insurance type, so we'll provide the care pro bono, which means you're not going to charge the patient. The third way would be to explain to the patient, obviously, and you should be talking to your patient regardless, but certainly offer to provide the services on a private pay basis. So you may tell the patient, you were referred for home health under Medicare beneficiary payment, but you don't meet the criteria for that. So we can do the services either free, if that's an option for your agency, or you can privately pay those services, and this is how much it's going to cost. Now remember, it is a condition of participation that the patient, in the patient rights, the patient is to be informed of what Medicare will pay for and what he or she is responsible to pay before the services even begin. So again, this just shows you that you need to be aware of whether or not they meet the criteria, whether or not they're going to have to pay any part of the care that they receive, and you need to notify them how much that would be up front so that they can make a decision. This is where the advanced beneficiary notice comes into play, in that if you are aware that Medicare may deny this payment and they're going to take a chance on Medicare not paying, that's when your advanced beneficiary notice would come into play, where you document that you told the patient you weren't sure they were going to meet the criteria, and that if Medicare indeed is not going to pay for those services, they will be responsible for some of the monies that you can bill them. If you don't do that at start of care, Medicare tells you you can't go back and do that later once you've admitted them. So you have to be really careful about how you go about admitting and understanding what Medicare is going to pay or not. Okay, let's quickly review some pre-claim review model facts just to help our memory. Now, the home health agency or the beneficiary can submit the request for pre-claim review. It doesn't matter from whom it comes, whether it's the beneficiary or the agency, but whoever submits the request does have to have certain elements covered in order to be complete for review. Those elements include the beneficiary information, the certifying physician or practitioner's information, the home health agency's information, the submitter's information, other information as required, and then your required documentation, which is your face-to-face encounter, for example, and so on. There are 5 required documentation tasks that have to be submitted for each episode. Remember, the face-to-face, for example, if you're sending in pre-claim review for subsequent episodes or research, you still need to include that face-to-face documentation with that as well. The first task, it says in the pre-claim review facts, is that you are to submit the actual face-to-face encounter note from the certifying physician that justifies the referral for home health services. Again, and we've talked about this several times in my seminars and webinars, they're not looking for a form that you filled out at your agency and that you sent over to the doctor's office and had them fill in the narrative sections. The MACs have even gone so far as to tell us if that is included, it would not be reviewed as part of face-to-face encounter. What they're actually looking for is the clinic records. So your doctor's office medical records or the facility that sent the patient referral to you, their records is what they're looking for as proof that the face-to-face encounter happened, that it happened by the correct type of provider, and that it happened within the time frame, the 90 days prior to or 30 days after admission to home health services. Now, task number 2, they're looking for home health generated records that have been signed, dated, and incorporated into the certifying physician's medical records. What they mean here is if you get the documentation from the physician's office or from the facility, and perhaps for the homebound status, they only document that it's a taxing effort. Well, clearly, that's not enough to show the criteria 1 and criteria 2 under confined to the home. But they have told us that the assessing clinician can supplement that by adding information that shows criteria 1 and 2 are met for confined to the home. And if that happens, we can submit the narrative portion of our OASIS and so on to CMS to further evidence that and that the criteria is met. However, before we do that, we have to submit that to the referring physician, have that referring physician sign off on it and incorporate that into their records at the clinic or at the facility, and then give that back to you and you send that signed copy, and that will pass the criteria check. What I recommend agencies do, by the way, on that, if you're going to submit information from your OASIS or other assessments, that you include a statement or have the physician include a statement that says, I have read and agree with this information. I've incorporated it into my medical records, and they sign that. That way, whether or not you actually have the record from their facility, they have a statement saying that they have done these things, and it is part of their records now, and you have a signature. That's just my suggestion, though. You may have other ideas on how to meet that criteria. The third task that they're looking for you to submit is the certifying physician's signed and dated plan of care. And remember, CMS has told us that a 485 is not a standard document anymore. It's not a supported document. However, it is the format that most of us choose to use still as our plan of care. What you need to know about that is that indicator number 26 on your 485 form does not meet the criteria for certification. It's missing part of the elements of the statement of certification. So that's why CMS and your MAC look for in the records that all the criteria are met, and that doesn't have to be on one certain form. It can be on a combination of several forms, for example. Could be on a discharge summary and a progress note and whatever else. But you do have to make sure all 5 of those points are met. Number 5 task, you also have to submit in PreClaim review medical records that meet each home health requirement for confined to the home. For example, the criteria 1 and criteria 2. You have to document that very well. Let's also remember that submitting a PreClaim review request is voluntary according to CMS. And I kind of chuckle at that because, yeah, it's voluntary, but if you don't, you're not going to get money at all. Or you're going to get money and it's going to be 25% less. So again, if you submit a claim without submitting a PreClaim review request, that claim, regardless, is going to get reviewed. So whether you do the PreClaim review request or not, they're going to look at the record. They're going to really review it for the criteria being met before they pay at all. And if you go ahead and get the okay and you didn't do a PreClaim review request, you're going to get 25% less payment when it clears through processing. And by the way, that reduction is not appealable and it cannot be billed to the beneficiary. So if you get 25% less, you can't turn around and tell the patient they have to pay the other 25%. Medicare says, no, can't do that. All right, let's talk lastly about the PreClaim review, MAC review timelines. Now, initially, the first time you send in a PreClaim review submission, the MACs are required to make their decision and notify the submitter within 10 business days of the receipt of the request. So let's say that you get all your orders back, you have all your required documentation, you go ahead and do your PreClaim review request on day number 30 of your episode. They have an additional 10 days, excluding business holidays, to review and notify you back. So that means you have at least 40 days into the episode before you even have a decision if you only send it on day 30. So again, with agencies, we really have to think about our processes and how we're getting plans of care and getting those sent out and signed, how we're going to make sure our clinicians are submitting documentation timely, because those timelines become ever more important in the PreClaim review environment. That decision notification letter will be sent, by the way, based on how it was received. So if you send it by fax, you'll get your notification by fax. If you go through the MAC's e-portal, you'll get your decision by the e-portal as well. And if you mail it in, which I do not recommend, but some agencies will do that, if you mail that in, you have to add additional days for them to mail paperwork from the MAC office out to you. So in that case, you may even be looking at day 45 or 50 to get your notification as to whether or not you passed review. If you get a non-affirmative decision, basically the MAC will let you know. They'll also let you know specifically what you didn't meet as far as proving the criteria, and they allow you to try and gather the information that you need and then resubmit for a second review and a second and third and however many you need decision. You can resubmit as many times as you need to, and resubmissions then have a 20 business day timeline. So they double the amount of time they have to review it after the first review. So in closing, in today's presentation, you have learned the facts that led to PreClaim review. You've learned the authority behind PreClaim review, and you've learned the triggers and red flags of improper billing and fraud as CMS sees those. Now, what I do want you to know is that I listened to a webinar earlier this week by CMS, and they were talking about PEPR reports. And a lot of agencies either don't understand PEPA reports perhaps, or they just haven't thought about using them or what they're for. But your PEPA report will tell you how your agency's billing practices and statistics line up with the national and state level billing practices as well. So you can really use that PEPA report to see if your percentages of LUPAs or outliers or certain other things line up with the state and national level. For example, you can see how much your episode payment average is as compared to the national level and the state level and the MAC level. You can also see how much therapy utilization you're billing for as compared to the national and state and MAC level as well. So that way you can use that with your QAPI program to really see if you have any red flags going on long before CMS should indicate or find those. We'll continue to talk about and we'll try our best to get some information about the PEPA reports as well and do a seminar or webinar on that as well. For additional information, watch our other PreClaim review webinar videos. In part 1, we go over the basics or what you need to know about PreClaim review. And coming soon, we're going to do a third part in this series called Passing PreClaim Review the First Time. And in that particular session, we're going to learn about what you can do to ensure that you have the correct documentation, what it is particularly CMS and the MACs are looking for, and how you can ensure that you get that documentation and have it ready for submission in a timely manner. Okay? So again, thank you for joining us today for our webinar. We know that you have a lot of choices in who you use for education, and we're glad that you chose Axxess. We definitely appreciate the fact that you take care of patients in their homes and all the things that you do to make sure they get the care that they deserve. For more information, certainly you can come back to Axxess.com. We have tons of webinars and trainings and white papers and blog articles on all of the latest changes with Medicare, anything from ICD-10 training to OASIS training to value-based purchasing, CAPS, you name it, we've got you covered, and we want to partner with you to make sure that you're successful. Again, thank you so much for trusting us, and we hope to see you again in a future session.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. At Axxess, we're proud to offer a variety of training resources to keep you in the know on industry news and updates. You can register for additional trainings and watch on-demand training videos through our software or at Axxess.com, where you can also find tutorials, online manuals, and answers to frequently asked questions. We're always just a call or click away. Feel free to call us at 866-795-5990 or email us at support@axxess.com. All of our expert client experience representatives have a home healthcare background. They've been in your shoes and know the industry inside and out. Join the conversation and connect with us on our social channels. We'll keep you up to date with what's going on in the industry and share resources to help you grow your business and improve your patient outcomes. Thank you again for your time today and for choosing Axxess, your provider of complete home healthcare services, software, and solutions.